Hello and welcome everyone. Today we'll be doing the literature review of the recent paper published in JAMA, that is Stewardship Prompts to Improve the Antibiotic Selection for Pneumonia, the INSPIRE RCT. Approximately 1.5 million adults are hospitalized annually in the US for pneumonia, making it the most common infection-related hospitalization. About 50% of these patients receive extended spectrum antibiotics unnecessarily. Current national strategy focusing on shortening the antibiotic duration or de-escalating from extended spectrum after microbiological results, but this doesn't address the early overuse. Exposure to extended spectrum antibiotics, even briefly, can elevate the risk of MDRs, Clostridium difficile infections, and other adverse effects. Common practice is to prescribe strong antibiotics like vancomycin or anti-pseudomonal therapy at admission itself, shifting to standard spectrum antibiotics only after negative screening for MRSA and absence of MDROs in the culture. Despite safety in using standard spectrum antibiotics for most of the pneumonia cases, clinicians often choose stronger antibiotics initially because they fear MDRO. The INSPIRE Antibiotic Stewardship Bundle was evaluated for its effectiveness in reducing unnecessary extended spectrum antibiotic use in pneumonia cases. This bundle includes computerized provider order entry, that is the CPOE prompts that encourage the use of standard spectrum antibiotics for patients at low risk of MDR or pneumonia, supplemented by educational efforts and feedback to the clinician. The study design and intervention. The INSPIRE pneumonia trial was a cluster randomized trial focusing on comparing routine antibiotic stewardship with the INSPIRE CPOE stewardship bundle in reducing the empirical extended spectrum antibiotic usage among hospitalized non-critically ill adults with pneumonia. The study included 18 months baseline period and a 6-month phase-in period and a 15th-month intervention period. Conducted at HCA Healthcare, the largest private community health care hospital in the US, involving non-ICU patients. The intervention. It received educational materials, hospital guidelines, and quarterly coaching calls to maintain stewardship as per national guidelines. This was the routine group. And the CPOE bundle group, in addition to these, this group received monthly coaching, educational materials, CPOE prompts to recommend standard spectrum antibiotics during the first 3 days of hospitalization for patients who are at low risk, that is less than 10% of MDR or pneumonia. The activation of the prompt triggered with extended spectrum antibiotics were ordered within 72 hours of admission. It recommended standard spectrum if the patient's estimated MDRO risk was less than 10. It was tailored to specific antibiotic ordered. For example, if vancomycin or cefepime was ordered, the prompt evaluated the risk and recommended alternatives if appropriate. So this is how it worked. The patient is in a non-ICU setup. Extended spectrum antibiotic is ordered to treat pneumonia within the 3 days. It triggers the algorithm which is initiated, and then it checks the patient's risk of pneumonia, that is MDRO risk. If it is less than 10, then prompt will recommend ceftriaxone as a standard treatment. It will recommend ceftriaxone as a recommendation. You have to override it to give something else. So this is how the screen will look like. So you must give a reason to override this prompt. If the patient is at higher risk, then no additional screens come, and if the patient is in ICU, then the algorithm is suppressed. So both study groups received educational material on the national policies and standard spectrum that should be given. Educational materials include presentations, handouts, and emails, all developed by the investigative team. They were disseminated through hospital channels by local study champions and leaders. Both groups participated in the coaching calls that emphasize avoiding competing interventions. Additional education material for CPOE. This group received further education on how MDR or pneumonia risk estimates were calculated, the information on the local rates of positive MDRO culture. Lead investigation often conducted site visits, additional webinars to booster the local educational effort, regular coaching calls were done, and feedbacks were taken. And hospital recruitment criteria. Hospitals eligible for participation were required to use the Meditech electronic health record system and agree to avoid initiating new measures that might influence the empirical usage in non-critically ill patients. Hospitals sharing clinicians under the same antibiotic stewardship program were treated as single unit for randomization purpose to maintain consistency in practice across all the trial. The study cohort included patients with discharge claim codes for pneumonia marked as present on admission, ensuring that all patients with pneumonia were included regardless of the reason for antibiotic prescription. The cohort did not include prisoners, patient transferred to the ICU within 2 days of admission. The Harvard Pilgrim Healthcare Institute Review Board cleared the study. Reliance agreements and operational committee approvals were obtained from participating hospital. Individual patient consent was taken and was waived in the view that this is an observational study. Now, hospitals were paired and then randomized in a 1:1 ratio, and either routine stewardship or CPOE prompt was activated. Pairing was based on similar baseline characteristics such as antibiotic use patterns, clinical practice, and patient characteristics. Randomization within the paired groups used the Mahalanobis distance method to ensure similarity and comparability between the groups at baseline, enhancing the reliability of the trial outcomes. The data source. Data was collected from the HCA centralized data warehouse, including comprehensive patient demographics, hospital unit locations, previous admission to the hospital or nursing home, inpatient antibiotic exposure, and comorbid conditions. Information on the race and ethnicity was included to enhance the diversity and the generalizability of the study results. Data on history of MDROs was gathered from the microbiology lab results, identifying various resistant bacteria like MRSA, vancomycin resistant enterococci, and other listed in the trial's supplemental materials. The use of the extended spectrum antibiotic was specifically tracked and is detailedly explained in the supplement of the study. Pneumonia caused by the MDROs was identified based on the positive culture results from various samples taken within the first 3 days of hospitalization, including during the associated emergency department stay. Trial outcomes. The main measure were extended spectrum days of the therapy during the first 3 days of hospitalization, counting each day on extended spectrum as it has been administered. This included specific days of therapy for vancomycin and antipseudomonal antibiotics. Antibiotics given in the emergency department the first day were also counted. These consisted of days to antibiotic escalation, days to ICU transfer, and overall length of stay in the hospital. Statistical method used the generalized linear mixed effect models to assess the unadjusted difference between the two groups. Random effects was used to account for the clustering within the hospital and across different periods. Data from phase-in period was excluded. Analysis details. The primary outcome was analyzed by a two-tailed significance of alpha 0.05. Each assessed the two-tailed significance at alpha 0.025 to adjust for the multiple comparisons involved. The safety outcomes were evaluated using the unadjusted proportional hazards model with random effects, with each safety outcome tested with a significance of one tail with alpha of 0.05. Now, some adjustment in analysis were done that took into account for the variability in the age, sex, race, and ethnicity, the insurance status, the antibiotic usage recently, the nursing home exposure, and other various parameters. Statistical software used were the SAS version 9.4 and R version 4. And the sensitivity analysis, the first analysis included patient transfer to the ICU after first day. The second analysis for safety outcomes, the patient who died were considered as having been transferred to the ICU, have had antibiotic escalation on the day of the death. For the length of stay outcome, deceased patients were assigned a length of stay of 30, reflecting the 99th percentile for the baseline period. In the third analysis, redefined the primary and the secondary outcomes as the number of extended spectrum antibiotic doses given per patient during the empirical period to provide a more clinically relatable metric. So finally coming to the results. So total 143 hospitals were invited, 5 did not have the system with them. So 138 were eligible, 79 declined to participate in the study. So 59 were randomized with 44,780 patients. 29 were clustered into the CPOE group and 30 were clustered into the standard group. So this is the baseline and the intervention period difference in the parameters of the in terms of patient number, age, sex, race, the ethnicity, the insurance status, various things. So overall you can see the age was somewhere around 68, and it was mostly the older patients, that is more than 65 were included in this particular trial, most of them being female, but then it was very small difference, 48 to 51. White were predominant, 78.6%, and various insurance status were there, like Medicare was the most common, which was around 70%. Antibiotic usage here is described. Overall, everything was similar in all the groups, even the history of prior antibiotics. So this diagram basically shows how the model was utilized and how much days of therapy per patient per 1,000 empirical days is given. So the orange here shows the filled one, shows the CPOE bundle in the intervention group, and this is the standard antibiotic, and this is the routine antibiotic. So as you can see here, the standard antibiotic usage was significantly higher in the CPOE group, and it was considerably lower. The filled ones are the CPOE ones. The filled ones are going down, so there is a increased usage of standard antibiotics and lower in the usage of the extended spectrum antibiotics. This is the points where the guidelines were new introduced and the COVID-19 pandemic struck. Now, this is the percentage of patients with pneumonia receiving the extended and the spectrum, or a combination of both. So similar thing you can see here with the CPOE, the use of combination as well as the extended spectrum is going down and the standard is quite up. So coming to the primary outcome, the extended spectrum days were significantly less in the CPOE group, and it was statistically significant. Similarly, if you look at individually, vancomycin or anti-pseudomonal all were significantly less compared to the routine stewardship. However, it did not impact the other parameters, that is length of stay, time to ICU transfer, and time to antibiotic escalation. So the CPOE intervention significantly reduced the use of empirically extended spectrum antibiotics among non-critically ill patients. The data indicates here that there is a very low incidence of MDROs, around 2% for pneumonia cases, especially in patients who are coming in from the community. The patient-specific prompts likely influence antibiotic prescribing in several key ways, that is shifting the initial antibiotic from extended to standard, providing guidance and reassurance to switching away from the extended spectrum, highlighting the importance of the local MDRO data, influencing the antibiotic choices in the emergency that can be given, ensuring sustainability of the intervention, and documenting each patient's risk of MDRO in the electronic health record. And it established a low risk threshold for MDRO at less than 10%, helping in standardizing this for clinical risk tolerance. Now, there are certain limitations, especially the generalizability. The study is conducted exclusively in private community hospitals, limiting its applicability in the public hospitals or academic centers, or even in the rural centers. For that matter, generalizability to other countries like India can be difficult. The inclusion of the culture results without assessing the specimen quality might have led to an overestimation of the pneumonia and the MDRO. The decision to set MDRO risk threshold at 10% could be questionable because there is no such threshold established as of now. A higher threshold might have been safe also. and may have been more effective. The simultaneous rollout of Inspire pneumonia prompts alongside those with UTI might have influenced the effectiveness of the intervention either positively or increasing the familiarity. Now, the isolated prompt effects. It is challenging to distinguish the specific impact of CPOE prompts from the overall effect of accompanying education and feedback effort. While rapid reduction in the antibiotic use suggests a significant impact of the prompts, the contribution of the education and the feedback element cannot be entirely separated. So we don't know for sure is this the prompt that worked or it was the education that was given that worked. Now, the introduction of the updated pneumonia guidelines during the trial, which emphasized the use of standard spectrum, may have influenced the behavior also. However, the distinct reduction observed only in the CPOE period suggests that the prompt did have a unique effect. So we can conclude that the CPOE prompt and the education has worked and it has reduced the extended spectrum antibiotic usage in patients of pneumonia, and it can be something which can be utilized in other countries or other hospitals as well. And we can also go up on the limit for the MDRO that we are taking, especially if we are thinking that it is 10%, or we can go up to even 20 to 30%. Thank you for your patience.